Hey guys, so this video is on inpatient insulin management. And so this is kind of, I feel like this is kind of a fun thing that you can do in the hospital, and it's not super complex. I think it's a skill that interns should be able to pick up pretty quickly, and then I think it's something that med students can do completely as well, and learn kind of during their first month or two on inpatient. Um, and then one kind of cool thing about this too is if you're going to practice outpatient management, you can get a lot of like good experience with treating diabetes just by being here in the hospital and managing people's insulin. And you can kind of develop like insulin management in the outpatient setting is different, but you can kind of still get like a good intuition for how insulin works and things like that. Let's see. So just first, some of the different or like one good resource here is this section here, inpatient diabetes guideline in the hospitalist handbook. So I mentioned that earlier, but it's got a lot of different sections, and it has more than I'm going to cover here as far as like different kind of particular things, like say the patient's NPO or different types of scenarios that you can quickly look up to know what to do. But I'm going to cover kind of the basics here. Um, let's see. And then just some kind of basic principles with insulin is like a lot of medications, like it's generally more safe to like start at a lower dose and then kind of slowly increase from there. Because it's the body, if your sugars are high, you'll eventually go, or for most people, they'll eventually go into DKA or diabetic ketoacidosis. But that does take the body quite a while to reach that state. Like the ketones have to build up, and those are acidic, and then your body, when the sugars are high, you diurese all your fluid. So it takes time to become dehydrated and acidic. Um, and then in the hospital, generally, well, not generally, we put in this order, the glucose monitoring order for people with diabetes. So the nurses are going to be checking the sugars every 6 hours. So I don't think, I mean, maybe it's possible, but I don't think it's possible to develop DKA within a 6 hour period. It just takes the body longer. At the same time, though, it is possible to die from hypoglycemia within a 6 hour period. And you could very easily, give to someone too much insulin, and within that 6 hour period, their sugars could get too low and they could die. So definitely, you a lot of times we err on the side of the sugars being too high in the hospital versus too low. Um, and that kind of brings us to the first point up here is what are the glucose targets in the hospital? Um, so in the outpatient setting, they're different, like per the ADA guidelines, but the ADA guidelines for the inpatient setting, they don't differentiate. And I was reading this on UpToDate. They don't really differentiate preprandial versus postprandial. They just kind of say it should be within this range. Um, I think there's differing guidelines saying that in some people that are not critically ill, you could shoot for a lower preprandial or like morning fasting sugar. I feel like most of us just shoot for this range, just to kind of be in a safe ballpark. And then reasons why you want to kind of be within this strict range, or like specific scenarios that are more important to do this are like if the patient has an infection, they generally will do better if the sugars are lower. And then UpToDate mentions that there's evidence for patients that have acute MIs, their outcomes are better if you keep the sugars controlled during the hospital stay. Um, let's see. So we'll talk about this. So the three different potential components of an insulin regimen. Um, and this doesn't talk about like an insulin drip, that would be something different, but just for kind of our normal patient in the inpatient and outpatient setting. And we'll get into these later on down here, but generally what we start with is like a sliding scale, also known as the correctional insulin. And what this is the nurse would give a dose of insulin based on what the patient's current sugars are. So say the sugars at this time are 300, then they might give like 12 units of insulin. And then basal insulin is kind of self-explanatory. It's just a long-acting insulin. The one that I've been using in the hospital is Glargine because it's just a once a day injection. It lasts like at least 24 hours, whereas the Detamir doesn't last quite 24 hours. So you generally would have to dose it twice a day. And then the last kind of component here would be nutritional or mealtime insulin. So this is given like during the meal or right before, and it's given without regard. Like they're probably still going to check the sugars, but it's given without regard to whatever the current sugar is. A lot of times we do it as an add-on to the sliding scale. So it'd be like the order would be like 5 units of insulin with each meal. And we'll get into that more down here. So we'll talk about first, like when we're admitting a patient. So say you're admitting a patient who has diabetes and they're on like a high dose of metformin. Generally, what we do is we stop all the oral, and there's some kind of caveats to this, but just as a general thing, we would, and I'm not going to go into this in detail in this lecture, but generally you stop the oral and then non-insulin injectables. That'd be like a Ozempic or one of those. So stop those medications and then put them on an insulin regimen. So what we would start is we start with a sliding scale. The order for this, and this is in the order set, the admission order set that I went over in one of the first videos. But otherwise, you can type in Novolog and then either the word high, medium, or low, and then you can pull up the sliding scale. And then the sliding scale, you have to use some clinical judgment, but you say the person's really like insulin sensitive, then you'd go more so with the low. And then some kind of predictors of insulin sensitivity and resistance are their recent A1Cs, their BMI, and then like current doses of their diabetes meds or how many they're on. Say they come in and they're on 5 different diabetes meds all at the max dose, and their A1C is still like 11, then that means they're probably super insulin resistant. So you'd start them at a high sliding scale. And then generally we don't start basal right off the bat, but like in that case, somebody like that, it's pretty clear that they should be on insulin. Like if you saw them in the outpatient setting, the next step, somebody has maxed out the oral meds, the next step is to start them on insulin. So in that case, we would start them on insulin. This was from up to date, like 10 to 20, or you can do it weight-based and calculate it. I've generally always started people on 10 and then kind of gone from there. So that's how you do it if they're not on insulin. And then if they are on insulin at home and you're admitting them, then you would keep them on their home insulin, but you decrease the dose by 25 to 50%. That's what UpToDate says. I've seen a lot of attendings who decrease it just by 20%. So you just kind of use your judgment. Like if you see the patient just in their room eating a ton of food, versus someone who has an infection, they're sick and they're not at all hungry, not eating, then that would make a difference. So you just kind of use your judgment, and then you would also start them on a sliding scale. If they do mealtime doses of insulin, again, use your judgment of whether you want to continue those or not. I would probably start off by just stopping those and seeing how much of the sliding scale they need. And then going from there, because you can always add those on later. Let's see. And then next is if the patient's NPO. And then this goes for if they're NPO like on admission, or if they've been here a week and then suddenly we're making them NPO, maybe for an upcoming surgery. So generally what we would do is decrease the basal insulin by 50%. And then we would, if we're admitting them, then we would start them on a sliding scale. If they're already here, then we continue whatever sliding scale they're on. And then we definitely stop any kind of mealtime insulin, obviously, because they're not eating meals. And then we would resume it once they're eating again. Okay, so now we'll get into kind of a more, the last section of this, which is kind of complicated. So I'm going to do an example at the end. So say someone is already admitted to the hospital, and then let's see, we'll go with our patient who was just on the metformin. So we stopped the metformin, and then these are kind of the three steps. And this is really important to know kind of how to escalate someone's insulin regimen. So we'll go through like step by step, the three steps of how to do this if somebody's sugars are just still high. So step number one is we increase the sliding scale. So the patient came in, we stopped their metformin, and then we started a low sliding scale, let's say. The first thing we do would be to kind of gradually increase that up to high so that we max it out. And then if their sugars are still high, and if their if their preprandial sugars are also high, then we would add on basal insulin. And you can do it how we talked about up there. Another way to like either 10, starting in maybe a 10 or a weight-based dosing. And then or you can do it, and I'm going to do an example down at the bottom, but another way to start or increase someone's basal insulin is, and it says it kind of summarized right here, but you take the amount of, like the total amount of the short-acting insulin that they've gotten in the previous 24 hours, and then you multiply that by about 40% or so, and then whatever that number is, you add on to their basal insulin, or you start them on that number of basal units. And then if their sugars still aren't controlled after that, then so you increase the basal until you can't go anymore. So there's this concept, or I think of it as like the concept of maxing out somebody's basal insulin. So you can only increase the basal insulin until let me just do this down here actually on this, let me see. So let's say that someone's sugars look like this throughout the day. So you can see they're pretty high up here, but the fasting sugar is on the lower end. So if we were to increase the basal insulin, yeah, it would bring down these numbers up here, but it would also bring down this one into kind of potentially the danger zone. So this patient, even though they're still high, as far as their prandial numbers, they're essentially maxed out on their basal insulin, so we can't increase it anymore from there. So what we will do is step 3 is adding on mealtime doses, which would just bring down these numbers. And then that's kind of the final step, basically. Let me delete these. Okay, so and let me see. Oh, and then the order for the mealtime doses is Novolog TID-AC. That means 3 times each day with meals. Let's see. Okay, so let's do another example here. Actually, I might just do kind of the same example, but draw it out so we can see it better. And then add numbers to it. So let's see. So let's say we admit the patient and then their insulin, let's say at this point they're on a medium sliding scale, and then their insulin still looks like this. So generally adding, like increasing the sliding scale will decrease the fasting numbers, like the preprandial insulin numbers a little bit. So it might bring them down to say here. But obviously they're let's see, obviously the fasting number is still kind of above this range, so you want it within the range. So let's say over the, or let's say we increased it to 10. Let me erase this line. And then over the last 24 hours, the nurse gave the sliding scale, the high sliding scale, and then the patient ended up getting 10 units here, 10 here, 10 here, and then also 10 for 10 before, whoops, that's a 10, so 10 before bed. So they got a total of, and mind you, the patient's not on any basal insulin at this time, so they got a total of 40 units on day 1 of hospitalization. And then so kind of using that method, we would multiply that by 40%. And then that equals 16. And so, and you can also do this, like I was saying, like just start them weight-based, or you could do it this way. But this seems, I've done this a lot, and it's generally a safe way of doing it. So you would take the number 16, and then you would start them on 16 units of basal insulin. And then let's say that brings their sugars down to like an appropriate range here. Let's say it brings them down to here. And then at this point, like kind of was showing in the other example, the basal's maxed out, so we can't increase that anymore. If it wasn't maxed out, though, we can continue to use the same calculation every day, and then increase it by 40% of whatever short acting we gave. But so this patient's maxed out. So then step number 3, like I was saying, is to add on mealtime doses. So that would be 3 extra doses of insulin. And then we would continue to increase those until until basically their sugars look more like this. Because it's normal for, like in all of us, our sugars go up when we eat meals, but they should be within this kind of tighter range. They shouldn't shoot up like this. And just as a kind of fact, a lot of times giving corticosteroids causes these postprandial sugars to really shoot up. So if someone's here for a COPD exacerbation and we have them on a lot of steroids, that can cause these to shoot up after the meals. Yeah, so say and you have to use, as far as the starting dose for the mealtime insulins, you just have to use kind of judgment. A lot of times they'll start at like 3, but it depends on how resistant they are and how much insulin they're getting. So yeah, let's say we do 3 at each meal, and then it brings them down to this nice range, and then that's kind of it. So we would be done with that, and then we would just continue to monitor every day. Let's see. And I think that's everything. Still have this drawing up here. That's everything. I have this this document's posted on the shared Google Drive. So if you want to look at this or print it off, you can feel free to do that. All right.